So I'm Michelle Harrison. I'm a medical oncologist and I work at Chris O'Brien Lifehouse as well as Liverpool. So thank you very much for coming today. And the topic I was asked to speak about was treatment, side effects and symptom management. So the first thing I'm going to say is that ovarian cancer encompasses an enormous amount of disease, and often when we're talking about things, and I'm going to be guilty of this in this talk, is we really focus on epithelial ovarian cancer. And we're not talking about those rare types such as, the ones that you've had, the germ cell tumours. And often when you're patients and you've got these rare subtypes, you get on the internet like everyone does and you read about ovarian cancer. And a lot of what you're reading is not applying to you because you've got a rare cancer. And so the first thing I'm going to say, just before I talk, because your question was wonderful, is that there is research being done into rare cancers. And I'd encourage anyone with a rare cancer to get onto a website which is called Cartwheel. And you can actually register online, and I can give you the details a little bit later. You can register online and then your tumour and your case can actually become part of research, and that eventually we will learn more about these cancers. So I am actually very interested in rare cancer research, but I'm afraid that this is mainly going to be, just for ease, mainly on the rare type, the most common type, which is epithelial ovarian cancer. It encompasses about 1% of the population, and it's the most common cause of gynecological death in Western society. Now, it increases by age. Like most things, the older we get, the more diseases we get, and cancer is exactly the same. But the median age across the board is going to be about 60. We find that it is associated with BRCA mutations most commonly, and you're also going to have a talk from Leslie Andrew because there are also some other genes which can affect your risk. But by and large, we most find that the BRCA1 and 2 are the most common genetic type, but most cancers are going to be what we call sporadic, so there is no genetic reason for most of the cancers. Now, a lot of people that I see have presented with advanced disease, but there are some early presentations, and you'll find that we have some people who have symptoms relating to your pelvic mass, and again sometimes it can be an incidental finding because you're having a CT scan or imaging for an unrelated symptom. By and large, most people will give a history over weeks or months of symptoms of just not feeling well. They might have abdominal bloating, they might have abdominal pain, they might have disturbance in their bowel function, or sometimes if they've got a lot of disease or problems within the chest, they may have shortness of breath. And it's actually really difficult because a lot of, who doesn't have abdominal pain and abdominal bloating and crazy bowels here and there? So often it will take a little bit of time for a diagnosis of ovarian cancer to be made, and patients often get very frustrated that they've gone to their GP on several occasions before a diagnosis of ovarian cancer has been made. But usually those patients were very advanced from the outset and there's no disadvantage to them, but there is just that frustration of sometimes it can be difficult because it can be so non-specific. So once people have got a diagnosis of ovarian cancer, the mainstay of treatment is going to be surgery and chemotherapy. Now, the way we determine who gets surgery first and who gets chemotherapy first is via really communications in a multidisciplinary team. So you'll find that we all work in teams, we work together. It's not the surgeon just deciding, but there'll be a presentation and there'll be a number of factors that the surgeon will want to achieve. So what he wants at the end of his surgery, or her surgery, we've got some beautiful females, I'm sorry, I just work mainly with males, of the surgeons, but what they'll want is at the end of their surgery to have no visible disease possible, or at best just microscopic disease. And there are times where they might predict that actually they're unlikely to achieve that, or a patient might be very unwell and unfit for surgery. So it might be that we give chemotherapy first. If we give chemotherapy first, we will then evaluate after 3 cycles, and if you've had a great response, we will offer surgery at that time, and the surgeons will hopefully do a fabulous operation for me to then give chemotherapy. So we also then have this concept of maintenance therapy for a select number of patients. And these things do change over time, and Chen's going to be talking a lot about research. But for the moment, there are 2 maintenance treatments I have available to me. One is bevacizumab, which some patients can, I've got another slide on this, and more recently, we've also got for patients who've got BRCA changes in their ovarian cancer, compassionate access for olaparib. So things are changing and things are improving over time. So anyone who has had epithelial ovarian cancer will know all about carboplatin and paclitaxel. It is our standard. We've been using it for many years, and I predict many years to come. And also, there are some patients that are just not fit enough for it, but actually just giving single-agent carboplatin is almost as good. So the maintenance therapies is one drug called bevacizumab, and this is one which actually works on the sort of vascular system of tumours. And we find that in patients who are at high risk, so who've got very advanced disease and got lots of disease left after surgery, or more advanced disease, so disease which is maybe outside the abdomen or diseases in the liver, that they seem to get a little bit of extra benefit from continuing this drug alone. And olaparib, which is actually a fabulous new treatment, part of the PARP inhibitors, is the only PARP inhibitor currently available in Australia, and very recently this has become available by compassionate access for some patients who have these BRCA changes. So everyone's going to be a little bit different. So you'll find that the experience of one person might be a little bit different from another. And sometimes when people are chatting, it's like, well, I've had this and, oh, I didn't have that. Why didn't I have that? But all of you are very different. Your tumours are very different. And so you'll find that the medical oncologist will tailor the treatment to you. So this is one of my beautiful patients. So she was 46 when she came to see me. She was diagnosed with ovarian cancer. She had a history of breast cancer for which she'd undergone surgery. She had very standard breast cancer chemotherapy as well as hormonal therapy. And then she had symptoms of abdominal pain and bloating. She came to me via the surgeon. She'd had a hysterectomy, bilateral salpingo-oophorectomy, which is removal of both fallopian tubes and the ovaries. She'd had an omentectomy, which is kind of this fatty tissue, which often is involved with ovarian cancer that had been removed. And then the surgeon will actually look into any other sites and remove any disease that they're able to. She had an excellent result at the end of treatment, so she had no residual disease. Her pathology was our most common type, our high-grade serous cancer. So I recommended 6 cycles of carboplatin and paclitaxel with her. Now, there are a few things that I'll actually think about when I'm looking at this patient. So the first thing is she had a history of breast cancer, and she did not have genetic testing. So I arranged genetic testing, and we found a BRCA1 mutation in her. The next thing is that she's actually had this D drug, which is docetaxel, which can affect the nerves. So I've got someone who I know is going to be more at risk of nerve changes when I give her chemotherapy. But anyway, that's what we did. So when I'm describing chemotherapy to my patients, I will actually kind of draw it out because, you know, when you say I'm going to do this amount of cycles and this, well, what does that actually mean and when am I going to get my side effects? So what I'll often do is I'll write it out and I'll have that this is day 1 and this is cycle 2. So these are each cycle, and it'll be one cycle for this one equals 3 weeks. So every 3 weeks you're going to come in and you're going to have your chemotherapy as an outpatient. When are you going to get your side effects? Well, that varies, but for most patients, and I do this with my little big cross, most of my patients are going to get these side effects really in the first couple of days to a week after treatment. And then there's this little cross in the middle, and so this is where we get our lower blood counts and things like this. This is where we're potentially going to be immunosuppressed. And so I'll draw it out like that so people kind of understand what to expect and they can cross them out as they go because it's always great to actually get them down. And then hair loss usually occurs in about this 3rd week after treatment. It usually comes out quite quickly with this protocol. In terms of the side effects people are going to get, sometimes people can have an allergic reaction. Now, this is actually quite scary and probably occurs about 5% of patients. So I actually like to have patients well informed about what this is going to be like. So the offending drug here is actually the paclitaxel. If you do get it, it is different for different people. So it occurs quite soon into the chemotherapy. You might find that you feel a little bit tight across your chest or your throat or a little bit short of breath or a bit dizzy or have some back pain. And the nurses will actually hover when they do this. So if this occurs, they'll take the infusion down, they'll give you some medication to settle it down, and then more often than not we're able to re-challenge it just at a slower rate and patients are fine. But it can be an incredibly scary thing for patients to go through. And sometimes I don't re-challenge with a drug for some patients. And I'm going to talk about some of these next side effects in a bit more detail as we go, but they might be tired, nausea, vomiting, appetite changes. Taste changes are incredibly common. I've had a few patients who actually are chefs, and I have to warn them to be very careful and to get someone else to taste the food. Because, no, seriously, I've had 3 chefs so far, is that often you've got a metallic taste, but sometimes people can lose taste and particularly lose salt taste. And so I've had a few occasions where patients have told me that mum's not allowed to cook anymore because they keep putting salt into the food and no one can palate it anymore. Aches and pains in the muscles and joints. We also then have side effects which are not related to the chemotherapy, but our medications actually to manage the side effects, such as constipation. That's actually from our nausea medication. The constipation can be really bad. Poor sleep. I give people big loads of dexamethasone. You can actually be quite hyper after that and have trouble sleeping. So it's really common for my patients to have poor sleep for a couple of days. And likewise, those steroids can sometimes cause indigestion as well. So not specifically a side effect of chemotherapy, but a side effect that you're going to go through during your course with chemotherapy. The Molar Suppression is what that little cross in the middle, that's your low blood counts. And we also talk a lot about febrile neutropenia, and patients are often very scared about infection and those types of things. So actually you don't need to be too worried about it. Most time if someone has a fever, it's going to be completely fine or a viral or nothing exciting. The reason we highlight it to you is there is a very rare chance of it being a serious infection. So if you let us know when you have a fever, we'll check your blood counts, and we may admit you to hospital. We will over-treat this a little bit just to make sure we don't miss that 1 or 2 patients that are going to be sick. So don't need to be too fearful of it. You don't need to wrap yourself up in cotton wool. I do want you to get out and about and try and maintain a normal life as much as possible when you're receiving chemotherapy. But if someone's sick, I usually just say just stay away from them. Sometimes people can get a sore mouth from mouth ulcers. Sometimes people can get diarrhoea and then the hair loss. Now the other thing with the paclitaxel, which does actually carry a lot of the side effects when you're talking about carboplatin and paclitaxel, is this neuropathy. And this is the one thing that may stay with you after the completion of chemotherapy. So this is the biggest side effect I dislike. And this actually can potentially be disabling for some people. They can't use their hand, they're tripping over things. So I'm always very careful when I'm giving chemotherapy to monitor this particular side effect, and also nail changes. The more chemotherapy I give, the more likely people are to get some problems with their nails. Again, they very slowly grow out. So, more specifically about nausea and vomiting, this is probably the most feared side effect other than hair loss in my patients. So people remember back in the day, and I remember when I was a young medical oncologist, before our nausea medications were as good as they are now, it's people being very sick, nausea, vomiting, uncontrolled, coming into hospital, being on IV fluids, and they honestly felt horrible. And there is this memory of that chemotherapy and that nausea and vomiting. And people often go, well, if I'm going to get sick, when am I going to get sick? Well, we've got kind of 2 phases. So one is within the first 24 hours, but then actually people can be sick and have nausea and vomiting even beyond that. And once you've experienced a bad nausea and vomiting, you can get what we call this anticipatory nausea and vomiting, which is, you're nauseous on the sight of me, on the side of my chemotherapy nurses, the side of the institution even. And actually, if we control our nausea and vomiting very well, actually we have very minimal anticipatory nausea. So it's really important to get control of this side effect. We've got a whole bunch of things up our sleeve, which is fantastic. So just this lower line is actually our prevention. So we're going to give you some medications in the drip beforehand, not only to reduce the risk of you having an allergic reaction, but also aimed at reducing nausea and vomiting, and we're going to give you some medication to take afterwards as well. And also, if you do have nausea, I want you to take through your medications with your metoclopramide or whatever else it might be prescribed, because I'll often describe for my patients when they say, I don't like taking tablets, and it's like, well, there's an easy way and a hard way to give chemotherapy. The easy way is to accept that you're going to have some side effects. Try and manage it as best as you can and have the best experience with the least side effects. The hard way is to actually just kind of put up with the side effects, which can be quite a lot, and kind of stumble your way through it. So we want to support you as much through your side effects and minimise them as much as possible. And actually, if you do have this terrible anticipatory side effect, one of my nurses used to call this vitamin L, called lorazepam. Fabulous, fabulous stuff. It actually can be really helpful because, it's a terrible thing, nausea. We want to minimise this as much as possible. There's been a lot of talk about medical marijuana. Really, in the space of chemotherapy, we don't have good studies on it. I do find it, for some of my patients, a very good adjunct for people who've got advanced disease for symptom management. But really for chemotherapy-related nausea and vomiting, I'm not really an advocate, and I think we can usually control it with our standard things. Now, this is a fabulous thing which I found many years ago, and this was a study of many thousand patients in the UK who were asked to report on their nausea and vomiting side effects from their last chemotherapy. And these were a range of all different things, not gynecological only, but actually 51% of patients didn't feel sick with their last chemotherapy at all, and 83% didn't vomit. And actually I think it's probably better now. So not everyone gets nausea and vomiting. I will say that most people will get a little bit of nausea, not much, and vomiting, usually not that much in my patients anymore. Alopecia, he's a cute little monkey, isn't he? He's beautiful. So it really does depend on the chemotherapy, and not all chemotherapy makes your hair fall out. Paclitaxel will pretty much universally. I've had some patients who've managed to have a few stray hairs left, but mostly I'm going to make your hair fall out. And we now kind of have these cold caps, and there are different types of cold caps, and you need to put them on before you give the chemotherapy, during the chemotherapy, and after the chemotherapy. Now, anyone who's had carboplatin and paclitaxel with the schedule that I showed up, which takes about 5 hours, that is 7 hours of having your scalp frozen. I have had some of my patients who have done this. Most of my patients with a 7-hour cold head will actually abort. It's not perfect. So we'll find that for carboplatin and paclitaxel, about 50% will actually have success, and success is actually rated not as in no hair loss, but maintaining enough hair that they feel that they don't want a wig. So I don't usually encourage people receiving long treatments to have the cold caps. I think they're better suited for people who are having shorter treatments, but there are some patients who do want to try it, and I have seen some patients who are able to cope with it. Sometimes they're sitting there drinking their warm tea, they've got their hot water bottles going, and a bit of a challenge. Fatigue. Now, if I had a tablet that could fix one tablet, it would be fatigue, because it's a terrible side effect for people to get. And some of it's going to be due to chemotherapy, but some of it's going to be due to a whole host of other reasons. So sometimes when someone tells me they're really tired, I'll actually think about, well, are there other sources of the tiredness? Is there anything correctable? Certainly the underlying cancer, well, hopefully if the chemotherapy works, the fatigue will improve. If you're anemic, I can fix that very easily by giving you a blood transfusion. There's going to be a beautiful talk with Kath Adams on psychological distress. This causes a lot of tiredness. Poor sleep, well, I'm going to muck up your sleep. Most of my patients have got very good nutrition, and sometimes other medication can also be the cause of it. But, when you're thinking about fatigue as a side effect, yes, you're receiving chemotherapy, but there can be other reasons, and so you want to actually think, is there anything else I can do to help this fatigueness? Fatigue with chemotherapy will go. After I finish the chemotherapy, I actually think it takes some time to go. It doesn't magically disappear 3 weeks after your last chemotherapy. I've spoken about the allergic reaction, bowels. my patients all have crazy bowels. They're either constipated or diarrhea or transitioning, so one of the things I'll say is just take something for it. So often people will come in and they'll say, I'm prone to constipation. I'll actually recommend that you manage your bowels early before that first chemotherapy, because I have had people say, actually the chemotherapy wasn't too bad, but I had 5 days where I didn't open my bowels and I felt terrible. So often we just need to be a little bit proactive about the bowels. Aches and pains, these can be anything from mild to excruciating. And they occur probably in about 40% of patients. So I'll say, look, the easy thing is, if you get pains, to take some pain medication. And I'll actually write people a script so that they've got something to take afterwards. Really can, it's usually self-limiting for a couple of days, but I actually have also found, anecdotally, that although it's not regarded as something long-term, that some people after chemotherapy will have aches and pains that even persist well after the chemotherapy is finished. Sometimes people can get rashes. It's not always related to the chemotherapy. But anyway, I'm going to save the last two for a little bit later on. So the neurotoxicity, now this is potentially reversible. So many times after people finish their chemotherapy, you might find that over the weeks or months that it might settle down, but you may be left with these residual changes. So it's incredibly important for me that you are able to function despite neuropathy. We have no prevention. So that's an active area of research. So if the treatments for, if you do have neuropathy, they're mainly looking at pain. So, and we often use the things that we use for diabetic neuropathy. I'm going to say that at the moment I think none of these are great. So you might find that if you're getting problems with this, that we either modify the dose of the offending agent, which will be the paclitaxel in this case, or we actually stop it early. And you don't need to worry if your oncologist stops it early. It's not going to undo the whole thing, but it may be saving you from having a terrible disability afterwards. Now, I always think with any talk, if we can throw in a little plug for exercise, we should, because it is an incredibly important part of cancer management. There is actually a COSA position statement on this of exercising in cancer. So I'd actually say that there are portions of our non-cancer population that would also need to exercise a bit more. But how much do we recommend? Well, what they recommend is 150 of moderate intensity. So moderate intensity is just getting your heart rate up a little bit, or 75 of vigorous, if you're someone who likes really vigorous exercise. They also want you to be doing resistance exercise, so that's kind of lifting or strength, and this is all about sort of making sure that we're not getting weak. About 2 to 3 resistance exercise sessions. Now, it also needs to be tailored because people are going to come into their cancer diagnosis with different level of fitnesses. They are also going to have different diseases. Some people will have difficulties with joint pains from arthritis. So it's actually great, if you're not familiar with exercise, in getting an exercise physiologist or a physiotherapist to help guide you, rather than going to your local gym and getting a personal trainer who does not know anything about how to manage exercise with cancer. You really want someone who is very well trained to do this. The other thing we know is if you exercise during treatment, you will also have a better quality of life through treatment, and you'll also have less fatigue. Now, I don't care what exercise my patients do. I want them to do what they enjoy doing. That'll be your best exercise. So, going back to my gorgeous patient, she actually did develop neuropathy, and I gave her carboplatin alone. And she had the standard list of side effects that you got. None of them were too actually bad. I'd actually say of all of these that she didn't like the most was actually metallic taste, was the thing that bothered her the most. Moving on to recurrent ovarian cancer. So the majority of patients who present with advanced stage disease are going to recur, but not all. So the mainstay is going to be chemotherapy, and for some patients, PARP inhibitors. And surgery is really indicated only for a minority of patients. So the mainstay is going to be with your medical oncologist with chemotherapy. We do arbitrarily divide this into platinum sensitive and platinum resistant. You may have heard these terms. The way we kind of think about giving you chemotherapy is really with how well you went to your last chemotherapy. So if you've had a really long break before I've needed to treat you, I'll probably want to give you the carboplatin again, and I may want to pair it with another drug that you've not seen before. But if you've recurred within a very short period of time, you're probably not going to respond very well to that strategy. So I'm going to give you a different drug that you've not seen before, and it's probably not going to be carboplatin. So for my lady, she recurred at 18 months. She had no symptoms. It was a raise on her CO125. I did a CT scan. There was really nothing for me to see. And I recommended observation. This is how she took it. My cancer's back and my oncologist wants to do nothing. It's really hard to do nothing at this point in time. So we know that if I give you chemotherapy at this time, you're not going to live any longer. Your quality of life is going to be worse. And I know that I can actually safely monitor you. And what I want to do is I want to give you chemotherapy at the time that you're going to get the most value from it. She doesn't need to get side effects from chemotherapy at this time because her CA125 might be 46. Nothing on a scan. She feels completely fine. This is also the most difficult consultation that I do, is when the cancer is back. It is the most devastating for the patient. And so then to have me say, oh, just do nothing for the moment, tough. But anyway, so we did that. She was uncertain. At 3 months I saw her again. Again, completely fine. Her CA125 went up. It's going to go up if I'm not treating you. But I did a CT scan and there was nothing that much there. And then at 6 months, she was still incredibly well. So she had 6 months. She didn't have any chemotherapy. Marks are going up. But when I had a look at her scan, I could start to see more disease. And I said, you know what, I think this is when I want to give you some chemotherapy. So I actually chatted about carboplatin and calyx. Now, that's not the only treatment. So you might find different oncologists do different things, or you speak on forums and people have had different things. That's fine. There's no one size fits all, and your oncologist is going to tailor your treatment to you. So this treatment, carboplatin and calyx, here, is given week 1 and then 4 weeks later. So we've got a 4-week cycle. And this one is carboplatin and gemcitabine, which is actually, you come in week 1, you get your carboplatin and your gemcitabine, and then you come back 1 week later for a top-up of the gemcitabine, and then we repeat that every 3 weeks. So as you can see, all of our treatments are a little bit different, but so we'll do different things, and I actually like to draw them out so people understand what they're doing, what's coming next. So these side effects are a little bit different. So you're not going to lose your hair with this one. You're going to have a risk of an allergic reaction, but it's actually going to be to the carboplatin on this time when we give it to you a second time. You're not going to have the nerve changes, but there are a few other things which are a little bit different. So you're more likely to get a sore mouth or mouth ulcers, and you're more likely to get this side effect called PPE, which is basically where you get red, sore hands, which can be blistering or peeling on your hands and feet. And actually there's no sort of cumulative late side effects with this one. So if you have trouble with mouth, we will actually recommend beforehand that you do mouth care, that you are, I don't care whether it's bicarb or whether it's salt, but just keep that mouth nice and clean. Don't use any of the over-the-counter agents. Often they've got alcohol base and they're no better. And also if you then have any mouth ulcers, they're usually going to be self-limiting. You just use some barrier creams or some analgesia. And also this PPE, these sore red hands, moisturisers. I recommend people sort of use hand protection, sensible footwear if you do get it. That's great when you're a female, and it's not good because you want to wear your high heels, and if you've got sore feet, just take care of them. So she had 6 cycles of treatment. She tolerated it beautifully and she had an excellent response to treatment. Now I'm just going to speak a little bit about her as to what happened afterwards. So at this stage, we knew she had a BRCA mutation. For her, I gave a maintenance therapy with olaparib. She did very well on this treatment. I actually accessed this compassionately via a compassionate access program at the time. She was on it for 18 months. She's had subsequent treatments after relapse. I gave her carboplatin and gemcitabine again. I then reused paclitaxel, and often there are treatments available, but they're not on the PBS. So she actually funded bevacizumab in combination with the paclitaxel, and we did well from that. And most recently I put her back onto the Calyx, and she's currently still doing very well and still has an excellent quality of life. So all my patients are going to have psychological distress. There is no way that you can have cancer and not have a degree of psychological distress. It is incredibly important that we don't just treat your disease, but we also look at how you're coping with things. And other things. So my patients may have tiredness, pain, swelling. They always have crazy bowels on me. They may have poor appetite, nausea, poor sleep, and sometimes people just have individual side effects. People often ask me what to look out for. I don't want you to look out for anything in specific, but if you do have something, let us know, and if it is persisting, then we're going to want to look into it a little bit further. So I'm going to give you another one of my gorgeous patients. So she was 62. She'd had 3 previous lines of chemotherapy. She was now actually running into a lot of problems. She was very psychologically distressed. She was very tired. She was in pain. She had poor appetite. Her bowels were constipated. So for me, as her doctor, this is what I think. At this point in time, I cannot cure her disease. My main endpoint is her quality of life, and I've actually got a lot of things which are impairing her quality of life that I need to work on. I will want to get psychological support for her. I will want to get palliative care. And people often think that palliative care is just end-of-life care. It is not. It is about maintaining your best quality of life, managing the symptoms, and for people with recurrent ovarian cancer, your symptoms from your disease can often be very difficult to manage. I'm very good at giving chemotherapy, and I actually think that the palliative care team are far more skilled at managing complex symptom needs than I am. So I will want to include them if I feel it's going to help you. So when your oncologist recommends involvement with palliative care, it's not because we think you're going to die straight away, it's because we want you to have the benefit of them involved in your care. And the other thing is, there gets a point where chemotherapy is not helpful and chemotherapy is going to be detrimental, that the cancer has become resistant to the treatment. And also, if I give you chemotherapy, I'm actually going to give you all of those side effects and none of the benefit. I'm going to make you feel worse. So stopping chemotherapy is not about no hope. I often have people who think that the moment we stop chemotherapy that they're going to die straight away. Well, actually, many people live long periods of time, not forever, without chemotherapy after we stop. And often, when I get them back at 6 weeks, they say they're actually feeling better because they're actually no longer having the side effects of the chemotherapy I'm giving them. So there will come a time to finish chemotherapy. Pain management. Don't be afraid to take opiates, I think is my take-home message from this. People are incredibly reluctant at times to take pain medication, and I've listed what I think are the top reasons my patients give me. Well, I don't like taking tablets. Well, my usual reply to that is I don't like seeing you in pain. I'm going to wait till the pain's really bad. Well, we need to titrate your pain to the level of pain you have. So if your pain's here, I want your pain relief to be here. And pain will change over time, so you might have more pain or, in fact, less pain. You just need to have the right level of pain relief for the pain you have. So we titrate it. We don't wait till it's really bad. If you have pain, you will feel tighter and you will have a poorer quality of life. So just let us give you some pain relief. I'll get addicted. No, don't worry about that. Take the pain relief. I'll get constipated. Well, you probably will. But the best way to manage this is to acknowledge that this is a very common side effect of our opiate pain medication, and you will just need to take some bowel support. So you will do much better by managing your bowels, by taking some things and taking your pain relief and not being in pain. It'll make me drowsy. Well, sometimes it can be a little bit drowsy. So what we need to do is we start gently. So we start at lower doses and then we titrate them up. So we'll often start you on what we think is a dose that you're going to tolerate. We don't head to a really high dose and knock you out, but we'll actually give you breakthroughs, and then we'll try and work out what's your level of analgesic need, and then we'll try and treat that. The pain came back. I get this one a lot. So what I explain to patients is your pain relief is like any medication. It works for a period of time. So things like paracetamol, those things, oxycodone, they will last for 4 to 6 hours. And the pain comes back not because the treatment didn't work, but because the cause of the pain is still there. So what you need to do is work on how you use your pain medication. And then the next thing is, I took it and it didn't work. What I usually think is, I've not given you enough. So if I've given you a pain relief and it's just slightly taken the edge off the pain, it's not that it didn't work, it's that the dose is not enough, and so we need to escalate. So, often when we're trying to manage pain, it's quite difficult, and it's why I think the PALCare team are really, really good at this. So we're good at sort of doing the simple stuff, but sometimes it's a little bit more complex, your needs. But there's a whole range of things where we need to just work on it, and we don't get it right the moment we start your pain relief. It usually is a little bit of working around about what's the brain thinks the level you need, and it's going to change over time, so we need to be reactive to it. Ascites. So for patients who've got recurrent ovarian cancer, this is a very common symptom that people get. Now, we can manage it with chemotherapy, but many times chemotherapy may not work because you become resistant. Acidic drainage is where we put a needle into the abdomen, just simply drain off the fluid. We can usually take several litres off at a time. People often find this an unpleasant procedure, and if they find it an unpleasant procedure, it's usually because they haven't received enough local anaesthetic. So I'll just the questions at the end. So I'll actually encourage someone that if they've had problems with this and it's been particularly painful, is to let the person know, and just you need to make sure that you get enough pain relief. Now, there's sometimes this problem that you seem to drain the fluid and within a week it's back again, and then you drain it off and then it's back again. So very rarely for some patients, just in that sort of last stage of life when they're having these problems with recurrent ascites, we can't control it with chemotherapy. The acidic drainage is becoming increasingly frequently. We'll put in just a catheter that can then be managed in the community nurses, and so they can often just take off 2 litres every couple of days. It is something which is a device which kind of sits externally, and that's never ideal, but it can be an effective way for us managing this effect. Bowel obstruction. Now, this is a not uncommon problem that we get in patients who have very advanced ovarian cancer. It is incredibly difficult to manage, and I will have the palliative care team and the surgeons both coming to see my patients. We hope that they resolve just by conservative management, so giving the bowel rest, giving people fluid, sometimes giving people some steroids to see whether that can help. Surgery is only going to help in a very selected group of patients, so it's not a case that we have an obstruction and that there's one area and that's it, and we just can go in and just fix that area. It is often that there's lots of disease in the abdomen and pelvis. There are often multiple sites. Sometimes it might be disease, sometimes it might be adhesions. So surgery is only going to be recommended for some patients where we feel that intervening is going to be helpful. Now, there's also this low residue diet. So I don't recommend diet too much to my patients with cancer because I get asked about diet a lot. But the one time where I will actually be very specific about diet is in people who are having bowel obstruction or bowel obstructive symptoms, because the natural reaction when you've got cancer is to clean up the diet, lots of fruit and vegetable, very, very healthy food. But if you're getting symptoms of bowel obstruction, a lot of those things, those high fibre foods, are actually going to exacerbate problems. They're going to overwork your bowel. So actually we recommend a low residue diet, for those people, I will often get the dietitian to come and help. There'll be little pamphlets and things. But this is probably the one time it will actually be very specific about diet. Any other time, I'm happy for my patients to eat whatever they like. So I'm going to just finish with every patient's unique and special. Certainly all my patients are to me. And I think we have hope for better outcomes in ovarian cancer. And the beautiful Chen, who's going to follow me, is actually going to talk about a lot of the research which is going on. We've got increased risk of genetic testing. And Leslie Andrew is going to spend a lot of time speaking on this. And so risk reduction surgery can occur in patients who have known BRCA mutations, but we don't always have the answers, and sometimes there can be family histories where there are very strong family histories and we can't find a gene. So every now and then with counselling, some people without a mutation may opt to have this done. We are getting incremental improvements in survival over time. We often look for the big change and things, but actually in truth we have all these little incremental changes, and over time our outcomes are just getting better and better and better. And we have a very active research in ovarian cancer. So I'm going to finish there, and I think you now get to ask me lots of questions.